Hello, my name is Mark Gyers. I'm an assistant psychologist working in the community pain service.
Hi, my name is Mohammed. I'm one of the pharmacists that works in the community pain service.
Fantastic. Mo, thank you for having a chat with me today about all things pharmacy. Just really wanted to start just by asking, of course, pharmacy is something that's regularly mentioned in the NHS and hospitals and community care. But for those who don't know, would you just give us a bit of an idea of what a pharmacist does, what their role is in the NHS, and specifically what they do in pain medicine?
Yeah. So as you probably know, traditionally a role of a pharmacist was working in a dispensary or in a chemist, what we used to call a chemist, and in a retail shop, and where they would check the prescriptions and the medications that were labelled before they went out to the patient. But over the years, the role of a pharmacist has expanded, as it has with other professions as well. And they've, the NHS has kind of realised that it's a very sort of resourceful profession that can do multiple things and do more things. And so the pharmacists have generally been upskilled, and they've done more and more different courses and things that are available for pharmacists to do, and so that gives them it widens their scope of practice really. So nowadays you get pharmacists working in all different areas. So you'll still have your traditional retail pharmacists that work in your high street chemists and things like that, but then you get your hospital based pharmacists who sort of run a more clinical service. So they go on the wards and they go around to each patient's bedside and review their prescription chart basically. And effectively the ultimate thing is that a pharmacist is considered as an expert in medicine, and so they're often advising the doctors on what doses to use, what medications to use, interactions between medications, and making sure things are being monitored appropriately, and making sure things are safe from a medication perspective. And then even within the hospital setting, you have so many different roles. So you have pharmacists that work in like a manufacturing unit, so they make chemotherapy and things like that, so in the production side of things. And then you have research pharmacists who work with like clinical trials and things like that. And then you have other pharmacists who have done like advanced skills courses, and so they work in like A&E settings where they're actually assessing patients and things like that. Then you get your academic pharmacists who obviously are involved in teaching and education and things. And then you have a lot of pharmacists who work in the industry, and so working for pharmaceutical companies and things like that. I think the key thing probably is that's made a big difference to the profession is the expanding the role for of a pharmacist as an independent prescriber. So myself as well, having just recently completed that qualification, it now allows me to be able to prescribe independently, and so it gives the rest of the team access to another prescriber basically. And so it also allows us to provide prescriptions to patients where we think that there's possible that there might be a delay if we wait for the GP to be involved and things like that. So it speeds up the journey for the patients and the GP and things as well, and it just makes the whole process a lot more safer. Now, so that's a role generally, and then moving on to sort of in pain management. Pharmacists in pain management is quite rare actually still. There's not that many roles like this current role that I'm in up and down the country. There are some pharmacists that work in hospital-based acute pain services as an extension of their role. So they might work as like a surgical pharmacist or a palliative care pharmacist or a critical care pharmacist, but they do a bit of pain management on the side kind of thing. So because of their role, they're seen as the go-to person, but it's not a specific role in that sense. This role obviously is embedded as a pharmacist is embedded into the actual community pain service, so it's working day to day with patients out in the community. So it's very different in that sense. And the pharmacist is as with the professions, they're one cog in the wheel of the service that we provide. So we obviously work as an MDT, or as a multidisciplinary team, and so we're made up of pharmacists, like people like yourselves, as psychologists, medics, and occupational therapists, physiotherapists, etc. And so we all kind of input our specialist and clinical knowledge and combine that with the knowledge and the experience of the patient, and then try and formulate a plan, basically, looking at all that. So it's a kind of a new role and an expanding role. But apart from the face-to-face clinics that we do, we have a lot of other roles as well, non-clinic based roles, so things like developing policies and developing medication safety, looking at this medication safety issues, medicines management, what we would call, audits and things like this, and making sure that ultimately, as a pharmacist in the team, you need to be confident that anything medicines related is being managed appropriately in the team.
I think one of the things that I've heard there, Mo, is it's quite incredible. I wasn't aware of how far-reaching pharmacy is in terms of all those different roles. And in relation to your role as well, I've obviously, with working with you, I've seen you wear a number of those different hats at different times. And I think what would be really interesting would be hearing what a sort of usual week looks like in the pain service for you. What does I know you work in Preston, you also work in Ainsdale with ourselves. What does a normal week look like for a pharmacist in a community pain service?
Yeah. It's a very busy week, yeah. I think, as you said, so obviously I work across 2 pain services, and the setup is quite different, but the ethos is pretty much the same, if that makes sense. And so, in the Southport service, obviously I work 2 days a week, on a Monday and a Wednesday, and so I run clinics on both days. One is actually based in Ainsdale, but the one every other week I do a clinic based in Southport as well. So at the health centre in the town, middle of the town. So that just increases the accessibility, because there's a lot of patients, especially with our cohort of patients, who find it difficult to access, Ainsdale, and so we provide a service from there as well. So I go there normally as well, every other week. So primarily, yeah, it's clinic based. So we'll have one-to-one appointments with patients, that are sort of pre-scheduled appointments, and that's either because there is a specific medication issue that the patient's concerned about and has raised with somebody else, or a clinician has seen them already and they're worried about something with regards to the medication, and would like my input as well. And sometimes it's we're trying to work the patient up towards the pain management program. So if we think that they're on a lot of medication that might be causing more harm than good, and we think that they might benefit from the pain management program, we sometimes have to try and reduce some of their medication so that they're able to engage better with the program. So sometimes it's for that, and then we often discuss patients before with the clinicians, or after. So if we hear or see something or discuss something with the patient, and we're a little bit concerned, or we think somebody else needs to be involved with this, and so we then take it forward from that appointment, and then discuss with other clinicians to try and, as I said before, make the best plan for the patient. So we don't just see them like one person sees them and then another person will see them and everybody's doing their own thing. We try and integrate everything together. The other time, the non-clinic based time, is obviously goes around a lot of the admin stuff, so writing and dictating the letters from the clinic, looking at any things that you've got following out from the clinic. So things like chasing up blood results, scan results, making sure that all that kind of side is you're happy with, liaising with the GPs. Obviously, because medication and the nature of the problems, we often get ad hoc calls from patients and GPs and practice pharmacists and nurses and things, asking for our advice, or asking for clarifications around medication and stuff. So often, even if you're just in the office doing admin work, you're often getting a lot of queries coming through, even if you're not necessarily doing them, face-to-face clinics. We also offer like telephone appointments as well. So sometimes it's not necessary to see the patient, face-to-face, or if the patient can't make it, then sometimes we would defer to like a telephone call as well. Aside from that, we do a lot of the medication management stuff. So we've recently developed some what we call PGDs, so patient group directions, where it allows the physiotherapist to be able to inject medication safely, for the patients in a clinic-based setting. And so how we manage all the ordering of the medication, the storage of the medication, and making sure it's safe, doing the audits for the fridge, and the temperature monitoring and all these kinds of things. So that's one of my weekly jobs, is checking the thermometer in the medication cupboard and making sure that the temperatures are audited properly, because the last thing we want is for the temperature to have gone out of range because of the heat, for example, and the medication isn't then safe to use, basically. Also the management of the prescription. So obviously the actual prescription pads, they need to be stored and managed safely and recorded and audited as well. So any prescriptions that we use need to be thoroughly audited. So that's tends to be the bulk of it. And then once a week, as you're aware, we have like an MDT as well. So all the clinicians gather together on that day, and if we have any specific concerns, or if we have any specific patients to discuss, we would then bring them to the table on that day, and while everybody's there, get everybody's input and try and again formulate a plan, basically, on how we do that. The other thing, I think the key role is with regards to the pain management program. So the pain management program is obviously a 8-9 week course, basically. One of the sessions is around medication and how we can get the most out of medication in managing chronic pain. So I deliver a talk on that as well, from the medication side of things. So that's a key role, because it helps the patients understand where medication fits in the management of chronic pain, and it helps to dispel a lot of myths as well. And so that's a really useful thing to get the patients really engaged with self-management and not relying just on medication.
Absolutely. And one of the things I've heard there, Mo, is actually around everything that you do is about patient safety, but also supporting the patient as well. And there's loads of things that are seen, but also tons of things that are unseen, so checking fridges and making sure that things are done safely. I think one thing that you mentioned there as well, I thought was really interesting and really refreshing, which was around, we aren't seen, or hopefully not seeing, the team as individual elements, but something that is a collective. So, not going to see the pharmacist and going to see the doctor, but actually there's been a lot of crossover. What have been the challenges, do you think, of working in MDT and overcoming those challenges? Being able to keep being an advocate for patients, their story and what they'd like. How do you keep that consistent?
Yeah, I think it's really interesting question, and I guess each day is a learning curve, and I guess the more you embed and integrate with the team, the better you're able to understand the perspectives of other clinicians. So, from a personal perspective, having worked with doctors and nurses before, it was a bit easier to integrate with them professions, but having not worked that closely with psychologists before, that for me personally, having joined the team more recently, that was a kind of a new experience. And so you can, I guess you could either go two ways about it, where sometimes people might become a bit defensive and not really engage, but then you can also use it as a really good learning opportunity and think, I've got another profession here that I'm not normally used to working with, and they've got a wealth of experience in this area, so how you can learn from them, basically. But I guess the key thing is obviously listening to other clinicians and their perspective, and really trying to be comfortable in your own knowledge and practice, but also be willing to be flexible and learn as well. So being able to challenge, sometimes you have to challenge, because traditionally, as a pharmacist working in a hospital where I've worked previously, mainly, it's a very medical model, and it's very directed by physicians and things, and so it's the focus is very much on medication, basically, whereas in a community pain service, but in a chronic pain conditions service, the management is completely different, and so we know that often medication is not the answer, and sometimes it can actually make things worse. And so where then do you go with patients? And so it's vital, and it's really, I don't see how a service could progress without these other professions, basically. And so you soon come to realize that actually perhaps my role isn't as integral alone on its own as I thought it once would be, or would be, but as a sum of the total, all the clinicians, it then makes it really important, basically. So I think being able to listen and learn from other clinicians and challenge your own behaviours and prejudices, I think that's really important, because a lot of times I've had to step back and think, this doesn't not sit well with me, but it doesn't agree with the way I've been trained and the way I've learned things all the way, and I'm having to work in a really different way, especially, for example, like the solution focused ways. For me, was a completely new approach, and you can put barriers up and say, oh, this doesn't work, but if you really engage with it, learn about it, try and implement it, then you start really seeing the benefits of it. So yeah, obviously it can have its challenges, but you soon come to realize that the more you integrate with everyone, the better outcomes for the patient ultimately. That's the most important thing.
Absolutely. I think that was a wonderful point you made there, which was, I've had to challenge, that I'm not my trainer might have said that I was one of the most important people in the room. I'm still important, but I am important as everyone, actually, collectively. I think that was a really sort of refreshing point, actually, you made there, Mo, which I'm sure people would be really happy to hear, that everyone has equal importance, including the patient you've mentioned as well, including the patient's expertise that they bring to any session as well. And that's really refreshing, actually. Again, one thing, Mo, when you were talking, I was thinking about as well, which is, you mentioned there about, perhaps medication in persistent pain conditions, again, on an individual basis, can be very helpful, but can also be harmful as well. And I suppose if we think about an example of a medication review as being mentioned, that's obviously, and rightly so, would cause a little bit of worry or anxiety in the person that, that session is being, invited for someone to attend. How do you work with when people do meet you in a room and say, "No, I'm really anxious that medication is going to be reduced," or what is the plan? How do you manage that?
Yeah, it's a really interesting question, and in all honesty, is probably the most difficult part of the job is trying to convey your knowledge, from a clinical perspective to the patient, but in a non-judgmental way, and not trying to impose your opinion, albeit it might be scientific or evidence-based, but you need to consider that in light of the patient's experience. Why is the patient reluctant to come off medication? You've got to understand that these patients are often chronic pain condition. They've got a chronic pain condition, and this is the only crutch or something that they've been relying on for many years, sometimes 10-15 years or even longer. And here you come now and tell them that oh, this is not good for you for whatever reason. And so although you might have a good reason for it, unless you can convey that to the patient accurately and clearly so that they're able to understand it, then you're playing, you're kind of on the back foot. So sometimes it's really difficult to explain tricky concepts from a medication perspective to patients in an easy to understand way, and that really brings out it really makes you think of how can I explain this really difficult concept, which even clinicians might find hard to understand, but in a way that I can translate it to the patient to really absorb that information. So that's a really difficult part of the job. But I guess the first key thing is important, is to listen to the patient. What are their fears? What are their concerns? Only then can you tailor your answer appropriately. If you go in with the sort of approach where, right, this is what the plan is and this is what we're going to do, and not really consider what the patient's feeling, then obviously it's going to be difficult for you, because the patient's going to feel like they're not being listened to. So firstly, I just let them speak and say, right, okay, what are your concerns? And I agree with them, and then say that, look, I totally understand that this is something that you've been relying on all this time, and now we're telling you to, we need to reduce it. So first, I try to explain to them and give them the understanding of why we're asking that. We're not asking them because we're trying to save money, or a lot of patients often say, oh, this is like you're doing this to save money, or to save costs and things like that. So we often explain to them that it's not about that. It's all about patient-centered sort of care, and they're at the heart of this. And if we weren't concerned about their safety, then we wouldn't be making these changes. And so often it's difficult to see, because a lot of times the patient might not be experiencing any problems per se, they might not be experiencing any benefit from medication, but they won't be experiencing any problems per se. But we might be worried about the use of it in the long term. So, for example, opioids is obviously a big hot topic at the moment, you know, internationally, I guess. And often patients will say, well, okay, I'm still in pain. Okay, I agree with you that it might not be working as much, but it's not causing me any side effects or nothing that I'm noticing anyway. So how then do you explain to the patient, like, you know, what are the long-term harms of these kinds of medications? So you're kind of trying to tell them what could happen in the future, and that's hard to engage with because it's not tangible, it's not in front of them. You know, if a patient says, I'm experiencing drowsiness with this medication, you can relate to that because you could say, well, this medication can cause that. But if you're saying to a patient, you know, this medication can cause you know, problems with your immune system, for example, in the long term, how do you get them to engage with that point, because it's not happening right now, if that makes sense. So trying to give them the understanding, and then ultimately having the approach, again, this is something that I found quite difficult, where you give them the information and then you give them time to absorb that. And so you say, look, you know, have a think about it. We're not here to kind of impose this and say the whole thing doesn't work unless the patient is engaged. And so if they're not on board, they could agree with me in the clinic, but go home and not follow the plan. So it's pointless, basically, if that makes sense. So we need their engagement. So if I think, you know, reducing X drug by, you know, 10 milligrams every 2 weeks or something is appropriate, but the patient feels that's too much, then what common ground can we come to, basically, and what to come to an agreement where the patient feels comfortable? Because it might take 4 weeks to come to the reduction, but at least we've got to that point, and it's better than. So I always say to patients is, there's no rush with these kinds of things. You know, this is a long-term condition and you've been on these drugs for many years. So us trying to come in and rush within 2 weeks and say we have to get you off this is a bit, you know, it can be quite difficult to understand from a patient's perspective. So I always say, look, let's take it easy, and I always say these words is, we're guided by the patient, basically. So I kind of empower the patient to feel they're in charge of this reduction. So if at any point they feel this is too much, I always, you know, encourage them to ring us up, basically, and say, look, I'm really struggling. I think this is too fast. Or actually, I think this is all right. Can I go even faster? Because I'd rather be off it sooner. So
Yes.
we let the patient guide us in that sense, and we just try to facilitate that. So it can be difficult, but I think the key is the education. So as long as patients usually have the understanding of why we're trying to do it and the rationale behind it and what we're trying to prevent, they're usually on board with things.
Yeah, fantastic. Sounds like you do a really good job in terms of listening to their concerns, and then being, you know, as collaborative as possible, and also as well working within that MDT team as well. Fantastic. Well, we could talk for even longer, but thank you very much for that. That was very informative. Thank you.
Thank you.